So I'm Nikos Evangelou, a neurologist from Nottingham. I'm the academic neurologist there with lots of my colleagues here. And it's a great honor to be asked to chair this session supported by Janssen. And the idea of the discussion today, and we hope there's going to be an interactive discussion, and trust me, will be provocative enough to promote interaction discussion, is, so are we doing the right things? Are we not doing the right things for the course of the disease? And because the time starts, and because some of you know me that I like my voice, we'll better start. So there is a slide, here it is the slide. So these are the disclaimers. This is who we are. Audrey, our chief neuroradiologist, possibly in the country, but we're very lucky to have her, and Tarunya, the boss of the MS neurologist with SIG. That's why I consider the boss. So we are very, very pleased. So in the beginning, I'm going to talk about the treatment after diagnosis. I'm going to talk about the early treatment as we know it. Audrey will tell us about, are we doing the monitoring all right? You know, this is practical stuff. You know, are we monitoring, you know, are we using MRI properly? And Tarunya will continue the discussion we started. You know, are we treating too many? You know, should we stop some of the treatment? So, you know, it's aimed to be a very practical session. So here we are, the disclosures. And there is a beauty in simplicity. And I think, you know, the beauty of simplicity, you know, has been, we have seen it again and again. And over the last 10 years, you know, I'm coming here to the temple of time is brain to argue that we oversimplify things. And I have Klaus sitting next to me, and actually that's why he probably sat there, so in case he would like to attack me very quickly. So have we simplified things too much? And this is the graph that we have seen again and again and again. And I think, I mean, this is too simple. I mean, we minimize, we simplify. You know, we're trying to show the obvious to the ignorant, but we are not ignorant. And this is complicated biological phenomena that I don't think we can simplify it. I think we need complicated graphs to portray the biological complex statistical material. And unfortunately, you know, I see junior doctors that I said, oh, I haven't started treatment for this patient with MS. And they are looking at me, you know, criminal, because I have been to this. And this is a bit strange. And when I say, and there is a bit of a discussion about how do we portray simple concepts like time. This is how children portray time. You know, this the second and the minute or whatever. But of course, things are not as simple. And I think that, you know, in you know, well brought up and educated people like we are allowed to be a bit more elaborate rather than quick, start now, otherwise we'll have terrible, you know, death and disability. So it is understandable, and we have seen that, you know, statistically speaking, if you take big groups of individuals and you compare it, and you compare the people that they have started the treatment 10 years later, they are not doing as well as people are starting early in the disease. But the question is, how early? And what is the effect size that we are talking about? Because, of course, the effect size, according to the graph, is wow. You start immediately and you prevent disability. You start 6 months later and you are doomed. So what do this is from the Swedish data. In the Swedish data, what have they said? We have analyzed a number of factors that determined disability, you know, and pensions 15 years later. And indeed, and this is, of course, one of the pieces of data that we have seen, but there are lots of other data, that there is also a gradient. And in this particular study, they have shown that if you initiate treatment more than 18 months ago, 18 months after the onset of the disease, as a group, there is a bit of a, you know, disability accumulation, more than if you start relatively early. And this is, just to put it in the context, this is the table. There is an effect. The hazard ratio is there. I can see, of course, a striking effect that the university education is significantly much more than whether you're starting 6 months later or a year later. There is even an effect, I mean, you can argue that it hasn't reached statistical significance, that whether you are married or not. So just putting this into the context that, we have concentrated, you can say we are doctors, we're neurologists, the only thing that we do is we are giving medicines. Just give the medicines because I'm not responsible for the education of my patients. Am I? Should I take this into account? Is socioeconomic parameters play a role? Am I responsible for this? There are some people who think that we should be taking a bit more role. But there is an effect that if you start early as a group, you are doing better. And of course, you can say we're talking, most of our speakers here, they come in the UK. They operate in the UK and they practice in the UK. We are not. Lots of people argue that these numbers are not correct, but there is a huge misdiagnosis in the US, and we're starting a prospective study of misdiagnosis here in the UK. And there was a couple of very nice papers being written because exactly there is this dilemma. Am I going to delay the diagnosis because we cannot start the treatment? Because that will lead to terrible disability and everybody will be on the wheelchair. Or am I going to get a secure diagnosis so I can wait for a few months? And the percentages, are striking. And what do we know about the percentage? We say that lots of people, I mean, these are graphs from the papers in the States, that they say lots of people that have been referred to the MS clinics, some of them we did not know a definite diagnosis. Lots of them were diagnosed at the end with fibromyalgia, and many times, whatever the misdiagnosis and the treatment that they have received carry on for years and years. And I was wondering, why does this happen? If we were a bit more cautious in the beginning, if we didn't have this time is brain, possibly we might have reduced the misdiagnosis. I wonder. So what contributes to the diagnosis of MS inappropriately? When we had criteria for neurological symptoms, that has happened sometimes, the historical criteria. When the people come along and say that, and I remember I had a bit of a numbness of my feet. And now I presented with a clinically isolated syndrome, so it is numbness of the feet, clinically isolated syndrome. Let's give the diagnosis of MS. Let's start some treatment. When we do not have any objective evidence of the previous lesion. When we're looking at the MRI, it could be MS, it could not be MS. Luckily, with the help of the team here, we might have the central vein giving us the answer. Klaus, you agree? So we might be a bit more clear. So the MRI will help us. But lots of times when you turn to the neuroradiologist, they're humans. They say, I don't know, guys. It's not correct. Sometimes it's not clear. So I think that we need to take a slight step backwards and say that if we are not certain, we are not be panicking by the time is brain. The other thing, because we have a number of psychologists among us, that you diagnose somebody with multiple sclerosis, and there is I have not experienced it, There is a wealth of emotions. There is fear. There is, I'm scared. I'm grief, fear. What's going to happen? And what we do, time is brain, let's start some treatment. And people would like to adjust. And some people take a couple of weeks to adjust. Some people take months and sometimes years to adjust. So what we have achieved, I think, over the last few years, we have done a big study of, how do we break the diagnosis of MS. And the people that they have been diagnosed with MS, eventually they told us, your MS nurses talk to us about DMTs more than everything else. And I think it's shocking that we have come to the stage now that our MS nurses are experts on this complication of this DMT, rather that, but they're not talking about who you are and how do you do it in a diagnosis of a disabling condition. So there are not that many people say, oh, nobody talked to me about DMT. So decision theory, if we go back to the science, says you take anxious people, you come along with your well training over the last 20 years, time is brain, you tell them, look, either we start now or disability is coming. And of course, you see everything negative. So you might sometimes force people to take an earlier decision than they would have liked to take. And I have seen it. I have seen it myself. So I, with lots of other people in this group, we try to run the Deliver MS study. And I know that some people have this fixed idea about the treatments. So I'm trying to capture people in Nottingham before they are polluted by the fixed idea in neurologists that they know that medicine A is the only medicine. So I try to grab them. And many times we found out, what are we talking about? We should not be talking about, the decision treatment of multiple sclerosis, trying to say whether escalation or early highly effective medication. What we need to be talking is about multiple sclerosis. And I have had the nurses coming along and say, Nikos, stop it. Let us see the patient. Let us discuss with them. Let's explore who they are, how they're coping with this, the diagnosis, and how they're coping with the prospect of a condition that does not have a treatment for the next 10 or 20 years, and then we can discuss about treatments. And this is how we do it at the moment. So we have had a number of people that they cannot make up their mind. Their mind is not up to scratch to decide about a local treatment. And, we discussed it before, there are a number of medications. At the moment, what we're saying is that start early. Who knows whether we'll ever stop? We still have a 10 years, 10, 15 years of data, but we're talking about a condition that will carry on for 50 years, for 60 years. So who knows how many complications from the various immunosuppressive medications we are giving at the moment. And the thing that you might say, Nikos, you might not have read the literature. What I have not seen the critical thinking of the evidence in multiple sclerosis. How do you translate the clinical trials, the black and white? This is what I have found in a 2,000 people study to an individual patient. And for the people that they like Nature papers, here is a Nature paper that they said, let's talk about antihypertensive treatments. And the antihypertensive treatments, the big trials, the sprint, and they said the more intensive you treat the blood pressure, the better it is. So there could be an option to say, fine, everybody will blast them with strong antihypertensive medications. But what about the adverse events? What about the individual risks? What about the attitudes to the condition? How do you engage the patients and talk to them? So if you have this idea, time is brain, then how do you have this conversation? So clever people have said that, as a matter of fact, if you take the individual risks and you apply it to the population, the red line are being harmed by taking antihypertensive treatment according to the regime that the clinical trials have suggested. The green, which is the majority, of course, have been finding beneficial. So we have our treatments. We say medication A is improving, is reducing relapses, but we have a treatment that has been applied to 1,000 patients, and it is very likely, I suggest, that we'll have 200 people that are being harmed and 800 people that are benefiting from the treatment. So the only thing I was saying that should we start thinking in a more gray area rather than the simplistic black and white. And of course, we have seen this graph before. There is a reduction in the effectiveness of the disease-modifying therapies. many people with, advancing age, further than the age of 50, they still need disease-modifying therapies. But certainly, there isn't, as a group, again, a difference between the traditional, the high and the low efficacy treatments after the age of, 40 or 45. And again, with this idea, the earlier you start, the stronger you start, the quicker you start everybody else. We are sort of ignoring data that reminds me of the antihypertensive medication that we should probably be thinking. So that's what I wanted, a little bit of an argument, a little bit of a discussion. Is treatment after diagnosis, is it always the sooner the better? Thank you very much. Anybody who's going to ask any question before we go to Audrey? Jeremy.
Nikos, very nice talk indeed. Is the problem we can't predict who's going to do badly and who's going to do well? Because we know there's a group of people who do fine in their lives, female sensory onset. There's a group of maybe young male aggressive spinal cord. Isn't the problem we don't have a good enough predictor at that moment with the individual characteristics? And isn't that, I know there's the modified Rio and things like that, but we haven't really got to a good enough predictor to know whether we can leave the situation or go in hard once the diagnosis is made.
I agree with you, and you can say, of course, why we didn't have a good predictor, because until, the last 10 years, I think, we start getting individual patients' data, and we can do the analysis, or some people. So the early years of our research, these data were prohibited. We didn't even know whether females and males were benefiting together because the drug companies were not releasing the data. And gradually, we're improving, and you're absolutely right. We don't have the absolute predictor. But I think it's worth thinking about the graph of the antihypertensive, that it is likely, just accepting that there is some predictor factors that which probably do not have them very good, but it is likely that some people are benefiting less than others, and possibly some people are harmed.
Isn't it we sort of need a kind of Q-risk predictor?
Yeah, we need
with millions of patient
Correct.
Points underneath it,
Correct.
Both clinical and MRI.
I fully agree. This is what we say. If we take all the data together. Dominic wants to ask you one question, and then we'll jump, because there is a little bit of a discussion at the end of the session.
So what do you say to the patient who you have delayed treatment to, and later on they progress, and you think possibly, or the patient is thinking, I may not be at this stage, had I been started sooner?
So, Dominic, that's a very good question. Of course, for the discussion, I appear to be taking a bit of a black and white situation. But what my argument is that we do not need to be starting treatment the week of diagnosis. We should not be so. People that they are having evidence of disease activity, with an MRI, you can see another lesion, you're starting. And my argument is that if you wait 6 months and you have another MRI and you can see another lesion, nothing terribly is being lost by having another lesion.
This is the point of attack master.
This is a philosophical argument we have with. It's a trial argument. So we'll find out the answer. So that's exactly the point. That I'm glad it is a London-based study, not having Klaus asking for my patients. So now I would like to introduce Audrey. So Audrey is a neuroradiologist with a lot of experience, and actually one of the few neuroradiologists with a clinical background who says, hey, I am going to sort out the MS MDT at her hospital, and she will tell us all the things that they go wrong at St. George's and all the things that they go wrong in the country. Audrey.
Thank you, Nikos. Thank you, Nikos. I think the fact that you've got a neuroradiologist coming to talk about monitoring in MS is a fair reflection of how much MRI we now do in monitoring MS. Now, when we're talking about, sorry, these are my disclosures, rookie. So when we're monitoring MS and using MRI, there are overlapping cohorts of patients that we're looking at. Those that are on DMT are the mainstay of the monitoring that we do, the monitoring MRI scans. But there's also a cohort of patients who are not on DMT, and it's less clear when we scan those patients, how often and how long for. There's also a cohort of patients on DMT that we scan for pharmacovigilance, and we tend to do these patients more frequently. Now with the approval of ocrelizumab and siponimod for PPMS and SPMS, we're doing more scanning of progressive patients to look for eligibility for treatment. And continuing Nikos's theme of there's beauty in simplicity, what we're looking for when we're doing MRI monitoring in MS is really quite simple. We're looking for evidence of disease activity in the form of either new lesions developing in the brain or cord, or gadolinium enhancement demonstrating an active lesion. There are other biomarkers of disease activity. You'll have heard much talked about, and you've seen a lot in the literature. I know Professor Giovannoni has done a lot of work on smouldering lesions and chronic inflammation in MS, these gradually enlarging lesions that show susceptibility artifact, demonstrating a breakdown in blood-brain barrier, which continues on. You'll see in the last few years as well, more has been coming to the fore about leptomeningeal disease, leptomeningeal enhancement in MS patients as a marker for cortical lesions and subpial disease. And there's been some work on diffusion-weighted imaging. I'm often asked in our MDT for where a patient hasn't had gadolinium and there's ambiguity about whether or not there are acute lesions, can I use DWI? And we certainly do see DWI, diffusion changes in lesions, and we had one patient who had a tumefactive lesion that showed changes. We scanned him quite regularly because there was a worry about whether or not it was actually tumour rather than inflammation. And you see beautiful DWI changes, but in the literature, there isn't enough, diffusion-weighted imaging isn't reliable enough an indicator to be able to to use reliably. So in the recently published Magnum's paper, published last year, the position paper, they discussed the paramagnetic rim, the cortical rim sign, and leptomeningeal inflammation, and concluded that we weren't yet at a place where we can use these for routine monitoring. So really what we're doing when we're monitoring patients with MRI is really quite simple. We're looking for new lesions, plus or minus gadolinium enhancement in a small cohort of patients. So I thought we'd look at what we're currently doing. Not terribly sure. There's still quite a lot of variation. This has improved over the last 5 years or so. There's been quite a lot of uptake of doing volumetric sequences, 3D FLAIR. However, this was a survey that we did in 2018. BSNR, the British Society of Neuroradiologists, did a survey across the country of radiology departments to see what different sequences people did at diagnosis and for follow-up. And you can see there is a huge range of sequences, and there wasn't much consensus about how we do it in this country. There was also a mix, as you would expect, a mix of scanning on different magnetic strength scanners. So the vast majority of patients in the UK are still scanned on 1.5 Tesla scanners. Magnums and quite a lot of the literature discusses how the higher magnet strengths demonstrate MS lesions much better. However, we also know that this, in the Magnus paper, that this doesn't improve diagnosis, it doesn't change how you would manage the patient. So actually scanning on a 1.5 Tesla scanner using a volumetric three-dimensional flare sequence actually is the most reliable way, the most reproducible between centres, the most easily comparable between when a patient comes between centres. So when we get referrals from the region, it can sometimes be very difficult to compare the different scans to work out if a patient has had a new lesion. And there's also quite a lot of variation about how we use gadolinium. Of course, this has reduced quite a lot since 2017 when the European Medicine Agency did their review of gadolinium. In MS monitoring, most centres now, well in fact all centres, really only use macrocyclic gadolinium. Linear gadolinium is only used in a very narrow cohort of patients. So, quite apart from sequences, there's also quite a lot of variation in the timing of when we scan patients. So it's not just how we scan patients, but when we do it. And whether or not we do cord imaging. So here is part of our algorithm in the draft BSNR ABN combined guidelines. It's still a draft, sadly. We've been trying to get this finalised for a number of years. Anyway, the recommendation is that when a patient gets started on a therapy, that you do a rebaseline at 6 months and then annual imaging after that. How long do we carry on imaging for? How long do we carry on doing annual MRIs on stable patients? There's no definitive answer on that, and we vary. The evidence is that it is most important in the first few years. So we've made a pragmatic decision to say that do it annually for 3 to 5 years, and then consider reducing frequency. So quite a lot of patients, you'd be able to reduce the frequency of MRIs to 2 or 3 years. Patients who have not commenced on therapy, again, we recommend doing an annual MRI for the first few years, because if you're seeing quite a lot of accumulation of lesions, then this might affect your decision whether or not the patient's decision whether or not to start therapy. Then, does this have a pointer? Yes. Sorry. Over here, RIS. This is another problem group, radiologically isolated syndrome. The recommendation at the moment is because we can't treat these patients without a clinical syndrome. So perhaps maybe one repeat MRI, looking at stratifying these patients. So if you've got somebody who's got a load of cord lesions, then perhaps you follow them up more closely. If you're reassured that there's no lesion accumulation, no cord lesions, then these patients have no need for further MRI unless things change. The recommendation for PML is according to the consensus group. that's Matt Craner and the others that's also been taken up. That's in line with the Magnum's recommendation for following up PML patients to do high-risk patients 3 or 4 monthly with a very attenuated sequence. So we do those really quickly because of the volume of scanning that we're doing at the moment. So what we do well, I think that rebaselining has become standard now. We rebaseline at 6 months because this covers the optimum period of DMT. Sorry, I've lost my power of language, because this covers the period in which you reach optimal levels of treatment. So at 6 months, because the different drugs will have different ranges from between 2 and 6 months, that we use 6 months as this covers. And this is really useful and gives clarity for further follow-up and enables early switching where you identify treatment failure. So you see that there's a tiny new lesion there, and this was on the rebaseline scan. So going forwards, we know that was there, and there's less ambiguity. I talked about the 3D flare sequence being mitigating the need for using 3T scanning. It also mitigates the need for gadolinium because the lesion conspicuity is so much better than on the 2-dimensional sequences. I'm not sure if how to get those videos. Nope, that wasn't it. Marvelous. Help? Anyway. Okay, so the videos are not going to work. I can't get... Oh, there we go. Oh, thank you to the IT gods up there. I think this is probably going a bit fast for you to see how superior... Can you play the 3D flare again? That you really get quite superior lesion conspicuity on the 3D flare. And that really helps when we can't scan all our patients on 3T. And it stops us having to give quite as much gadolinium. When should we give gadolinium? Patients who've got, this really isn't projecting terribly well, but patients who've got very confluent lesions, it can be very difficult to pick out a tiny new lesion in that. Gadolinium can be very helpful. Patients who've had a long interval, scanning interval, you could consider giving gadolinium because that could help. And essentially, where you've got a long scanning interval, you're not quite sure where you're at, and we want all the tools that we can get to help us with difficult decision making as to whether or not the patient can go on treatment. And that includes the progressive patients. Quite a lot of this patient cohort that are coming through now, the treatments, ocrelizumab and siponimod, are licensed for early progressive disease and want evidence of disease activity, of active inflammation. Now, if the patient hasn't had a scan for a number of years, and we think that beyond 3 years, it would be quite difficult to prove that lesions that have accumulated between a scan greater than 3 years before are active. So we would maybe use gadolinium on a one-off after a long gap. PML surveillance. So patients, I said we do a really attenuated study, so just a couple of sequences, so it's a quick scan and we can get these patients scanned through every 3 or 4 months. If they develop a new lesion, then we bring them back and give gadolinium. So the gadolinium is useful in that setting. And it's also important when giving gadolinium that we leave enough of a gap, enough of an interval between injecting and scanning for optimal uptake of gadolinium. So the ideal is 10 minutes. The MDT, I think the NHS England recommendations for complex patients or patients going on high-risk treatments to be discussed at MDTs has really increased the number of MS MDTs across the country. This is our MS MDT in 2018. For a number of years, we met face-to-face every week in a small, dark room. It was very cozy. And in the pandemic, we went online, and it felt like going underground. And this wasn't quite as pleasant. However, it opened up the MDT and made the MDT really accessible to teams across the region. So we now have teams across the region routinely joining. It's easy to dial in and out of the meeting. And what I think works best in an MDT is to have enough information about the patient. It's impossible to discuss the patient without enough clinical information. Ideally, we'd like the clinician looking after the patient to discuss the patient. We sometimes do it if we have enough information, we can discuss it in the absence of the clinician, but it's not ideal. And getting imaging across is always a tricky one. I think that not all MDTs have access to a neuroradiologist. Why have a neuroradiologist in the MS MDT? I'm not sure what value I add. I am sure what value I add. I think that over the years, I've helped with decision making in that it's useful to have a neuroradiologist who goes to the meeting week in, week out. I know what the issues are. I've got my eye in. And I think MS is one of those things that you do get your eye in. If you work a lot in it, you are going to be a little bit more skilled. So having a neuroradiologist, I think, reduces delays. It helps with decision making because you're not having to go back and forth back to neuroradiology. The other thing we don't do well, and for good reason, is the cord. The cord is a very small structure that we're trying to image. There's also variation about how much of the cord we image, when we image the cord. We know that there are asymptomatic cord lesions that occur, and therefore it is ideal to image the cord. We also know that the majority of cord lesions occur above T5 level. So magnums have suggested that it would be an acceptable compromise to just image the upper part of the cord unless a patient has signs of symptoms of a lower cord lesion. However, it is ideal to image the whole cord. And I think magnums have said that axial imaging is not is optional, but I find in day-to-day practice axial imaging is essential to be sure. Reporting still not standardized, and these are the parameters that we think we need to look at: new and enlarging lesions, volume loss. A few other things that we don't do well at the moment are looking at biomarkers of neurodegeneration, looking at brain and cord volume, postpartum patients. And I think this will all become a lot more important. What's on the horizon? I think we're going to be doing a lot more cord imaging. Magnums have talked a lot about this. They published a paper last year and another one this year about big MS data sets and how we should be harmonizing them for studies. So I think we're going to be doing a lot more volume looking at neurodegeneration. We're going to be using more, there are quite a few companies that have been around for a number of years. There are difficulties with volume measurement and using these automated, semi-automated systems, but they're going to become, they're already coming to the fore. So the key aspects to MRI monitoring: the importance of the rebaseline scan, the importance of isometric volume scans. Cord imaging is important because it helps stratify patients with clinically isolated or radiologically isolated disease, as well as relapsing and remitting MS. And going forward, I think we're going to be looking at a lot more neurodegeneration. and trying to standardize the way we scan patients, both in the planes and the sequences we obtain. Thank you very much. Any questions?
Any questions about the call? Do we have anybody? Yep.
Hi. Thank you very much. It's quite a useful talk. Two issues I've come across in our MDTs where there is quite a bit of variability between the different scanners or different companies making machines and radiologists being expert at their own scanners, and then those transmitted to the regional MDT. And then comparison across time, so looking at scans 2 years ago versus 6 months ago, and especially looking at things like PML, 3 to 4 monthly scans, there is this concern about a false reassurance. Also, how realistic is it to get 3 to 4 monthly scans for patients, even with limited sequences? I just wondered your thoughts about the two issues. Thank you.
Yeah, it's these sorts of practical issues that make monitoring complex because, like I said, the underlying principles are really simple. It's the application of it. I think that it is doable. There are not that many high-risk patients who haven't been switched that will need PML monitoring, so we're not finding the volume. So in theory, before this all started, or when it all started, we thought 3 to 4 monthly imaging is going to be impossible, but actually the volumes are not huge. With regards to differences between different scanners and over time, this is what's good about the 3D flare sequences. Often, when you pick up a lesion that was present before, but not, say, on a 2D scan, when you go back to that same spot, you can actually see a hint of something there. So, and this also ties in with my point about why have a neuroradiologist who does the MDT week in, week out. You get your eye in for different scanners. So I've got used to not just our own scan, but struggling, firefighting week in, week out, looking at different imaging and just developing. It's like street fighting in neuroradiology, just finding these ways of being able to cope with the differences. So I think that, yes, the challenges are there, but they can be overcome, and this is what's useful with the 3D, the volumetric sequences. The volumetric T1 sequence may also come in useful, will also come in useful for volume measurements. And then they're also, when we're looking at, over the next few years, we'll be looking more and more at neurodegeneration, and people are looking more to use advanced imaging, looking at diffusion tensor imaging, magnetic transfer ratios to look at the breakdown of the microstructure and the breakdown of brain connectivity, which manifests itself in neurodisability and cognitive dysfunction in the MS population. And I think that's where we're heading.
I just wonder about the MRI Elastogram and whether that would have any application in cases without new lesion, but still with progression, especially with the cognitive decline.
Yes,
and
right.
Whether there is a room of modifying the elastogram to something similar to fibroscope that's being used in the liver diseases as to be applying it to the brain.
Yeah, this is what I'm talking about. That's exactly what I think we're going to be focusing more in the future, because there is disease beyond lesion accumulation that we're not capturing on MRI at the moment, and people are busy looking at how we do this, how we capture, looking at thalamic volumes, looking at all grey matter volume, cortex, basal ganglia, measuring whole brain volume, looking at diffusion tensor imaging, because that shows you the integrity. Measuring diffusion in the brain gives you a measure of brain integrity. I keep losing the power of English. I have no other language either. But there will be these other ways of imaging the brain that are being worked on currently, currently being used a lot in research, but not in clinical practice, that will be coming more into clinical practice. How long it'll take, I can't tell you.
Fantastic. I think that was great.
Thanks.
Okay. I think it's certain that in 5 years' time we'll be meeting here and you will telling us, whether anything has changed or the same thing. Who knows? Who knows? Tarunya. Tarunya, I introduced Tarunya. Most of us know Tarunya. Tarunya is a consultant neurologist. She's an active clinician, one of those that see the patients rather than pontificate from a lecture. And she's also the one with the most connections in the MS world as being the chair of the SIG, along with Klaus, I think.
Yes. Thank you very much, Nikos, and also to the organizers for this opportunity to speak today. So what I'm hoping to do perhaps in the next 15 minutes or so is to bring together some of the conversations which we've already had in the last couple of days. So a lot of it might seem repetitive, but really complementary to some of the sort of points perhaps raised by Emma yesterday and Amit earlier. So when we're dealing with a neurological condition, which is chronic, disabling, and without a cure, and with a DMT scene, which has been gratifyingly enormous in the last 20 years. So we've gone from 3 disease-modifying treatments in sort of the early 2000s to over 17 treatments, with more coming on board, more treatments getting regulatory approval. What we've now got to do is essentially try to think, is it really time to stop disease-modifying treatments in a cohort of patients, and is it the right thing to start treatments in some of our patients? So those are my personal disclosures. And so essentially, I think, again, treating an incurable condition has got its challenges. Equally, I think having so many disease-modifying treatments then raises a question from the patient in front of you, who you will be treating for a number of decades, as to whether at the point of diagnosis, whether being on a disease-modifying treatment long-term has got its implications, and what is the implication of stopping those treatments in these patients. Now, we all know, again, things which have been repeated to us again and again in the last few years. Time is brain, so we need to crack on and treat our patients early. So we know from a number of recent studies that treating brain patients early with disease-modifying treatment results in less loss in brain. So we've essentially going from a normal healthy adult who's got a 0.1 to 0.5% chance of losing their brain volume every year to over 1% in an MS patient who you leave untreated. So really there is a lot of drive to really start treating patients early. Again, just to sort of cite one of the numerous papers which we've essentially had in the last few years, essentially to talk about some of the things which Nikos was highlighting earlier, was it really, I think, starting treatment early. So if you delay it by a few years, you've essentially lost a bit of time. So for each year of treatment delay, you're moving on from the EDSS, low EDSS to a higher EDSS, and that's essentially progressing quite fast, at just over 7%. Now, all that is on one side, but what are the reasons which might essentially provoke somebody like me or you, and also some of our patients, to start thinking about when we stop treatments at all? So these stop a treatment can be temporary. So we know we have conversations with our patients in clinic constantly, ladies, sort of young ladies, wanting to conceive. So we might want to stop treatment, or rather halt treatment temporarily during pregnancy, or switch to a different treatment or a washout period. Or sometimes we end up having a number of adverse side effects. So again, with the treatment scene constantly changing, you're acquiring things like lymphopenia, hepatotoxicity, graver risks such as PML, risks from opportunistic infections. But hopefully, these would then result in a temporary cessation of treatment, and rather than actually stopping treatment. So you might essentially think about switching the patient to a different treatment, or de-risking them by monitoring them in a different way. What would perhaps be a bit more difficult, I guess, for all of us, is essentially deciding when to stop treatment when none of that is the problem. So a patient's progressing on treatment, do you stop it? The patient is then aging, as we heard earlier from Amit, what do we do with a patient such as that? Now, there's some going back, I think, in pathology to think about these, and there's an argument for and against, and I don't think at the end of this talk there is going to be a conclusion if you're looking for one. So really, I think looking at the evolution or the pathobiology of MS, we know that this is a continuum, so it's not a disease and then it moves on to a different disease. So essentially the quantity of the problem changes over time, whereas qualitatively we are essentially looking at the same disease. So in the early stages of the disease, as you can see from the top as part of the slide, you've got both the plaque, the periplaque white matter, and also the cortex and the white matter all infiltrated by macrophages and microglia. However, as you move on with the disease, that changes in that there's a depletion of the cell types within the brain, and this happens with aging disease. However, we also know from recent studies that progressive MS, about 40% of patients with progressive MS, or patients who are deemed to be progressing with their MS, have got what we call smoldering lesions, or what we call these chronic active lesions. The margins of these pathologically have got microglia within them, and when we do image these patients, we've got a different scene. So those iron-laden microglia are basically demonstrated on MRI, such as the susceptibility-weighted imaging, with these areas where you essentially have an iron rim, and these iron rims can vary depending on what you're looking at. So, and where in the course of the patient's disease. For example, in patients with relapsed and remitting and secondary progressive MS, as their disease goes on, the volume of these iron rim lesions essentially increase, and the non-iron rim lesions essentially become smaller. So really, there's pathology which is ongoing, in a microscopic fashion. Even when you're not sort of seeing them on the standard radiology, which we all sort of know about. Age is, of course, one side of the whole picture. So we know that from our previous talk that there isn't a consensus, but we do know that things change within immunologically as people age. So when you're electing for a disease-modifying treatment in an elderly person, you've got to bear it in mind that their CD8 T cell responses, both to infection and vaccination, are not sort of very similar to someone who's younger. So there is that consideration overall. Now, this is a very large study from British Columbia, which essentially looked at the relapse rates in men and women who would, from onset of the disease and also by the patient's current age. And what became really apparent is that the relapses in the overall population, the relapses went down as the patient became older. That does not necessarily mean that the different age groups, people are sort of having lower or higher relapses. So people obviously in their early 20s have a lower relapse when compared to the peaking population at the age of 30, and then that sort of goes down. So certainly there seems to be a trend of decreasing relapses with aging disease. Now, what about the inflammatory signature? So what about the signature, which we sort of see rather than sort of the clinical markers, the biomarkers, various other aspects? So again, with an aging population, this is another sort of Swedish study which looked at patients' CSF and their axonal and inflammatory markers within the cerebrospinal fluid. So they did a very clever principal component analysis and essentially demarcated patients who as per age. So those yellow dots you see are people over the age of, or under the age of 54. So as they sort of cut off on their analysis, and the blue dots are people over the age of 54. And as you can see, there's quite a segregation in that patients who basically, as they become older, these CSF markers then start to diminish in patients So the aging population have not only got sort of changes which are happening microscopically, but also on their serum and CSF biomarkers, you start seeing changes which show a trend. Now, all that said, what is the evidence for discontinuation of a disease-modifying treatment? So I don't think I'm alone in sort of saying that this is perhaps one of the most difficult questions in clinic. I find this more difficult than actually telling someone they've got MS is when to discontinue treatment and what's the evidence behind it. Now, again, there isn't a dearth of evidence as such, but there isn't a consensus. So this is a study which essentially looked at patients with benign MS. It was interesting in that only about 35% of patients had a single relapse. So all the other patients had had more than a relapse. On an average, people were relapse-free for over 12 years. So it was quite a long period without a relapse. But only 5 out of the 136 patients they looked at essentially showed MRI activity or actually showed a clinical relapse when they stopped the DMT. And what was interesting again about the cohort with these people who actually relapsed were the younger patients, so sort of not the older patients. And certainly people who had a relapse closer to the time when the DMT was stopped tended to have either MRI activity or a relapse. A younger population, active scan, would basically be someone who would sort of be at high risk. Italian study, again, looking at a large population of MS patients and looking at people with relapse-remitting patients who'd essentially had no disease activity or no evidence of disease activity as marked by MRI, a lack of relapses, or disease progression for over 5.5 years. And what you can see is that people who've got longer time, so longer you go without any of those or you have achieved neither, then you become more, you're less at risk of having a problem if you had your DMT stopped. Now, this study which looked at the older population. So obviously, again, a huge dearth of evidence in the older population because of the exclusion from trials of these patients. So really, this is a population of patients who'd been on an injectable disease-modifying treatment for at least 7 years. So people who'd been on DMTs for at least 7 years. And what was apparent from this is that the stayers and the stoppers, so people stayed on DMT 3:1 stayers and stoppers, the people who stopped their disease-modifying treatment essentially followed the same curve. As you can see, the survival curves are pretty much identical to the patients who stayed on those treatments. So no real change within between the first relapse and stop of their disease-modifying treatment or their disability progression. Now, this was repeated again in another study a few years later, which essentially showed pretty much the same thing there's a larger study, pretty much the same thing for between stayers and stoppers for their annualized relapse rates, but their progression was faster. So patients who stopped treatment progressed faster than people who didn't stop treatment. Now, again, is there something like stable relapse-remitting MS? Do we all believe there's something like stable relapse-remitting MS? Now, we know from the Tysabri data, so this was a pooled analysis of and the Tysabri studies done over the years. And what then came to light was that people did relapse once their Tysabri was stopped. They didn't necessarily rebound, so people didn't really go on to have relapse rates higher than before when they actually started on disease-modifying treatment. But really, within 4 to 7 months of stopping Tysabri, people are already having relapses at that point. Again, another bit of information, which essentially shows that within a year of stopping disease-modifying treatment, 50% of people had actually had a single relapse with Tysabri. This study was interesting because it included secondary progressive MS patients compared to people before onset of treatment, 3 years before stopping DMT versus 1 and 3 years after stopping disease-modifying treatment. Very reassuringly for this population, again, which included both secondary progressive and older patients, showed that there was a fairly stable trend. Now, this is a difficult one. So I think counseling a patient who wants to fall pregnant or wants to conceive, and then you've got to counsel them about what is that relapse stopping or switching treatment, particularly patients on high efficacy treatment. You switch them to a low efficacy treatment or move them across. So what this study showed, which is a relatively small study, arguably, that patients who stopped disease-modifying treatment, planning for a pregnancy, were then having relapses 11-fold higher than the patients who had baseline. So essentially, they were getting higher at risk of having relapses. But equally, they also, postpartum, their relapses, albeit not as high as during pregnancy, also had it. So there's kind of very strong argument, perhaps, to think about continuing treatment during pregnancy, obviously within the risks. Now, the last sort of, couple of slides really. So this is us sort of talking about evidence, talking about sort of, what is it that we do with this patient in clinic who's pregnant, who is aging, who is progressing in clinic. But what about people's perspective? So what does someone who's sitting with you in clinic actually think about this all in terms of, giving you that information? So there are a number of studies which have looked at the patient's perspective, but this, in a very dedicated fashion, asks the patient, what do you think if you stop your DMT? And actually, people who had been on a DMT for over 5 years said, we don't really want to stop it. And only about 10%, a little over 10% said, we want to sort of carry on, we want to actually stop our DMT, see what happens. And if you look at it closer, there were patients who were older, there were people who had lots of side effects on treatment. So really, I think the consensus from the patient's perspective, now this is a very small study, so I'd like to sort of highlight that, but I think we need more information, more data from the patient's perspective. So what the aggregate view, so this is a struggle. So this is not black and white, and we need to start treatment. So I think if you have a lower risk, so you have a younger patient who has got a low EDSS score and a very high number of inflammatory lesions, I don't think that's I don't think we would be in a dilemma as to what we're going to do with that patient. Is the older patients who've got longer disease stability and people who've got low EDSS scores. Could we think about these patients and think about whether we want to stop treatment in these patients? And that is a question. So I think what we want to, so in conclusion, so there isn't a conclusion for this problem, which I think we're probably going to grapple with for a number of years. So there are prospective studies, which might shine some light, but I don't know how many of you feel that that's going to solve the problem. I don't know whether it is, but we will have the results of the DISCO-MS study not long, if not seeing it at ECTRIMS, we'll probably see it next year at some point, which will then tell us, is it biologically possible that it's possible that we actually can discontinue treatments in a cohort of patients. And would the million-dollar question, if you stop treatment, monitoring these patients, speaking from my own clinics and from our own experience, our clinics are so heavily populated with disease-modifying treatment patients that if I stop treatment, my ability to follow a patient up in clinic would become difficult. So as a MS clinician, I worry about that. From the patient's perspective, they worry about being lost to care. So, the progressive MS patients and their management remains a huge challenge in this country. So overall, I think that was all I was going to say. Thank you very much.
Any questions about discontinuation of treatment? Please.
Yesterday, I was amazed to see that NEDA is only 10% of people on interferons and 30% on the stronger group, stronger drugs. Have we? And I was interested that you said that if we stop DMTs, even when we think patients are their disease is quiescent, within 6 months there's evidence of relapse. Have we rather overplayed the NEDA card? Should we be actually not worrying so much about NEDA, but actually just saying, let's keep you on something?
So, I think that's an excellent question, actually. I think the boundaries of NEDA as a marker, and where do we stop? We've got NEDA 9, NEDA 8, where do we stop? And what do we include in the core NEDA is a question. I think someone asked a very pertinent question as to what happens beyond MRI relapses. I think cognition of patients, fatigue, and their long-term kind of outcome remains a huge challenge. And I think and almost certainly, I think disease-modifying treatments perhaps have got a role in that when you're not measuring it. So so I think the data is there, but they're only measuring what can be measured in a clinical trial at the moment, and what we need is a bit more expansion, I think, into what we're looking at as a part of a trial setting.
Radha from Nottingham, thank you very much for the very nice talk. Would you stop treatment in a 50-year-old monoclonal who has PIRA? And what do we do with people on PIRA, the progression dependent of relapse activity? Thank you.
Thanks, Radha. So again, I think measurement science of looking at it. I think Audrey's just highlighted what we can see on an MRI and what needs to happen sort of beyond what we can actually see. As we've sort of said, these patients do have smoldering lesions. I mean, age is group data, so obviously, again, one needs to look at this in an individualized setting. So if my 50-year-old, as you say, had a disease which they have, I don't think I would be treating them any differently from somebody in their 20s, so that is the point. And again, I think progression of disease has to be looked at with a little bit of a pinch of salt, because progression has got several dimensions beyond it, beyond relapses, and you're absolutely right.
Yeah, my question is, to what degree we're kind of overplaying kind of NIDA as an outcome, but from a slightly different perspective. In that, I mean, we are quite clear, and we've learned that yesterday and today, that there are limitations to what we can do, right? So, I mean, the drugs that we're currently using are marginal gains, probably more in the very beginning and probably a little bit less as the disease progresses, because other processes play such an important role. But I think that it can't mean that we kind of throw out essentially the baby with the bathwater of the marginal gains, however large those margins may be. So I'm just saying that, yes, of course we have. I mean, you could argue that the existence of PIRA as the dominant factor in disease progression suggests that everybody essentially has secondary progressive MS from the beginning. Okay? So I think my argument is to say, don't overplay sort of what we can even potentially do with the current crop of drugs, because we've learned in repeated talks that there's much more involved as the disease evolves.
Your main point is that we need to be open-minded and looking for the treatment for the PIRA, for the progression.
I would say that over 60% of the disability is accumulation through that. So when you're in EDSS 4 or above, you should probably all sign up to Octopus.
No, absolutely. Absolutely, to see how much, if any of these medications contribute. But because we have listened to the argument of Radu of the 50-year-old, what about the 75-year-old? Because Amit told us that there is a shift in the prevalence, and we see lots of 70-year-olds in the clinics. Do you stop any of the 70-year-olds, or young at heart? That's what it counts.
I think one can't get away from the fact that you have comorbidities which then increase, and those comorbidities are not always measurable, which becomes a little bit of an issue. So I think if you've got a 70-year-old patient with active disease on their scan, my sort of treatment of that particular patient would be very different from a 70-year-old who's been on disease-modifying treatment for 10 years and it remains stable. So I think it's all about de-risking treatment and choosing the right treatment for that individual patient. I mean, I've got patients on siponimod who are in their 80s, but equally there are people in their 50s I wouldn't give that treatment to, purely because I think it's unsafe for that particular patient. So I think it needs to be a fairly individual approach at that age.
Just on the issue of stopping treatment, there is, of course, the example of epilepsy, which is a relapsing remitting condition, where it was shown that if you stop anticonvulsant treatment after 2 years of freedom or longer, then you have a significant 25% risk of recurrence compared to those who don't stop it. And it has changed the law. If you do the trial and you show that you have recurrence of such and such, you have proven the point that the EMTs are worth the money we're spending. On the issue of whether you're going to treat early or not, in stroke you have 4.5 hours to treat it with thrombolysis, and in TIA you have 24 hours to do the job. And on the issue of neuroradiology, if you think back to the days before you, when we used to do air encephalograms, carotid angiograms, ventriculograms, and myelograms, and all sorts of things,
I think neuroradiologists should be cherished and should be part of the DMT.
And with this, I think this is the statement just before lunch. Let's cherish your neuroradiologist, and I can hear a bit of a rumbling noises there, so I think it's time for lunch. Thank you all. Thank you all. Thank you for Janssen to organize it.